Chancellor Gonski, Justice Kirby, colleagues and friends, thank you for inviting me to come to this evening and to come out tonight. I'd like to talk to you really about HIV/AIDS in the developing world, and is there a way forward for this problem. So I want to talk about four areas: the state of the epidemic, the failure of prevention, something about treatment access, and then a little bit about my favourite topic of advancing how we deal with this epidemic, which is research. So the state of the epidemic, I think, has been summarised already. This gives you a distribution around the world. You can see that it's sub-Saharan Africa which is most affected, but South and Southeast Asia are already becoming very problematic with explosive microepidemics. So we have 33 million. This is the UNAIDS estimates for 2007. 2 million died last year, and we saw that from previous presentations. The effect on demography is quite profound. In one of the highest hit countries in sub-Saharan Africa, Botswana, where the prevalence of HIV infection in antenatal clinics is around 40%. You can see the sort of projected population structure in 2020 in the dark blue, and what a population structure looks like in a typically developing country, middle-income country, normally. And you can see this tremendous contraction in the very young, the productive, and in the old. Why do we have to make the fight against HIV, including access to HIV medicine, a global priority? Well, clearly there's a humanitarian reason. Everybody agrees with that. Economic and social development in a disease which affects young people and young adults will not occur unless we treat the young. Tuberculosis, the tuberculosis epidemic has resurged with a vengeance in the developing world with multi-drug resistant tuberculosis, and this is fueled by the HIV/AIDS epidemic. And the other major issue is what Daniel was touching on with issues about climate change and food shortages is global security. If you have population disruption on the scale that HIV causes in some countries, national and international security is threatened. The forces for change have been extraordinary. It was only 12 years ago where we found out in rich countries that highly active antiretroviral therapy, combination of 3 or more drugs, actually worked. It wasn't until 4 years later, with a lot of groundswell, that people said, well, why can't we have these drugs in poor countries? But everyone said, well, they're just too expensive. And it wasn't until the World AIDS Conference in Durban in the year 2000, first time that we've had the World AIDS Conference in the developing world, that people from rich countries, doctors, scientists, policymakers, actually saw the impact of the epidemic in a middle-income country like South Africa. As a response to that, the UN had its first special session devoted to a disease, and by 2003 the UN had created the Global Fund, and also the World Health Organization became involved. Very shortly after, the WHO announced its 3x5 program to treat 3 million people by 2005. It wasn't successful, but it certainly catalysed change. Certainly some people got onto treatment. And extraordinarily, PEPFAR, President Bush's emergency plan for the relief of AIDS, probably the only good thing that the Bush administration has ever done, took off in 2005. And extraordinarily, it's being renewed in Congress this month for $50 billion. So that is very gratifying. The second UNGAS session occurred in 2006, and there'll be another one this year. What changed all this? Well, certainly global treatments activism was extraordinary, and people from the developing world saying, well, why can't we have these drugs? Generic competition from generic manufacturers, particularly in India and other countries, was extremely helpful in forcing the prices down. The funding mechanisms such as the Global Fund and PEPFAR became available, and we started to implement technical programs. You can see here the growth in services in the Global Fund. So this looks at three measures of what the Global Fund are doing in the three priority diseases. In the number of people on antiretroviral therapy increasing to about 500,000 by 2006, and they're getting up well into around 1 to 2 million now. Directly observed therapy for tuberculosis also increasing quite nicely, and very impressively the distribution of insecticide-treated bed nets for malaria has also been a very successful aspect of the Global Fund. However, it's just not enough. And we need to improve the coverage of these programs. What about prevention? Why has prevention failed in the last 20 years? Well, it's been covered, I think, fairly well tonight, but it's certainly related to lack of access, and particularly the main tools of prevention, condoms and clean needles. We've heard very clearly about how vulnerable many populations that need access to these prevention strategies are, and the cultural context in many countries, although needs to be overcome, is a significant barrier. Have a look at this. This is the global condom need of about 24 billion, and the global condom distribution about 6 to 9 billion. So the current funding supports about 3 condoms per year per man in sub-Saharan Africa. Now, you can see everybody benchmarking that against their activities, and it's very easy to realise how vulnerable that makes the average young person in sub-Saharan Africa. And to fill that gap is 57 million US dollars a year. So perhaps we should think about that as a priority. Women are vulnerable, and we need, as Juliet said, to have female-controlled prevention technologies. Female condoms certainly provide an alternative to male condoms, but they're more costly, and there's still, unfortunately, the possibility of male control. Why do we desperately need an HIV vaccine? A vaccine is the usual way to control epidemic infectious diseases traditionally, and we've been very successful over the years in doing that for many epidemic diseases, eliminating polio and smallpox and so on. And the effect of other prevention measures and the sustainability of behaviour is not possible for every person, and that is limited. But only about 5% of people in the developing world actually have any access to these prevention measures. So the expectations, unfortunately, are pretty bad. None of the vaccines currently in the pipeline is thought to elicit the typical response of neutralising antibodies which make vaccines work. So that's how polio works, that's how hepatitis vaccines work. We can't do it. We can't get a neutralising antibody response currently to this virus. So the best we can hope for is what's called a disease-mitigating cytotoxic T-cell immune response, which is the other arm of the immune system, in which what will happen is people will still become infected, but the vaccine, the T-cell response, will control the amount of virus, and therefore the people are less likely to get disease and less likely to transmit. That was the premise of the Merck vaccine, which you will recall failed miserably last year, and possibly also enhanced infection in some people who received the vaccine. Live attenuated vaccines, such as we use for polio and yellow fever, is a no-go with this virus. So what should we do? Well, we need to intensify the search for an effective vaccine. And unfortunately, the obstacle doesn't really lie at our ability to test vaccines. We obviously, with these trials, the Merck trial was an excellent example of a well-done vaccine trial. We just don't have the right basic science to understand how to develop a vaccine right now against this virus. And we need to intensify the search for alternative strategies for biomedical prevention, such as microbicides, taking oral prophylactic drugs, so taking the antiretroviral drugs to prevent yourself from getting infected, just like the oral contraceptive pill prevents pregnancy. So the same sort of principle, and those trials are ongoing. What should we do? Well, we have to intensify our current prevention efforts, and that's where prevention scientists looking at behavioural prevention really come into their own at this point in time. People like Juliet and the other social scientists at this university are in a major way contributing to this effort. So ways of improving education, fighting stigma, promotion of condoms, and making sure we have harm reduction strategies, particularly clean needles in these sort of explosive microepidemics that are occurring in many, many countries in our region. I think we should be implementing male circumcision, particularly in countries which have generalised epidemics. We have a 70% reduction in infection. If we had a vaccine that had a 70% reduction in infection, it would be stuck into people in no time. So we really need to get this on the move. And it's very important to link prevention to treatment, because when you get people into care, you can start telling them about how to not pass on the virus. So, treatment access. So just a couple of simple things about the pathogenesis of HIV. On the top half of that slide, you can see a graph of viremia, the amount of virus in the blood, versus time. So what happens when you get infected, you get a massive replication of virus. After a few weeks, the immune system comes in, drops the viral load down. The lower that viral load is, the less likely you are to infect someone else. The viremia persists for many years, during which time you can transmit, and eventually the viral load actually increases as the immune system fails to control it. On the bottom half, you can see the massive depletion of CD4 cells in the body that you get following that infection. So these are the main cells of the immune system which are attacked by the virus. As the immune system comes in, that returns to normal, but there is still virus around, and there's this progressive destruction of the immune system over many years. Average about 50% over 10 years will get to a critical level of their immune system, whereby the number of CD4 cells will be inadequate to fight serious infections and cancers. We now have, thanks to science and the commitment of the pharmaceutical industry, the presence of, or the ability to use 4 classes of drugs to interrupt the life cycle of the virus in this infected cell. And they include reverse fusion and entry inhibitors, reverse transcriptase inhibitors, like AZT, one of the first drugs that we used, a very new class of exciting inhibitors called integrase inhibitors, which look very potent and without side effects, and the protease inhibitors, which revolutionised highly active antiretroviral therapy in the mid-90s. What has the impact of that been? This is the impact in Australia. And the impact has been the same in every rich country of the world, where people have been able to access these life-saving treatments. So here you can see, these are our data from the National Centre, and what you can see beginning in the mid-1990s, when highly active antiretroviral therapy became available, the drop in AIDS diagnoses in the red, and the drop in deaths due to AIDS. Quite dramatic, as you can see, reproduced everywhere else in rich countries. You can see the number of new infections in the top blue diamonds, and very disturbingly, unfortunately, is the increase over the last 8 years in new infections that are occurring in Australia, from about 500 in the late 90s now up to almost 1,000 a year. And this is a good example of it occurring in states which have taken their eyes off the ball in having official HIV prevention strategies from health departments. So how's the Global Fund doing, for example, of getting coverage for treatment? Well, this is what's happened over 3 years. It's pretty miserable, pretty miserable. So 15% are getting coverage with antiretroviral therapy in the people who need it. The mother-to-child prevention, awful, right? Single dose nevirapine, you know, you're covering 5 to 10% of women. And to actually treat pregnant women to prevent transmission, again, the coverage is very, very low, and we just have to do better. And even worse is the number of children on treatment. So we have to really scale this up. It's a jigsaw puzzle, and we've got to get not just thousands of people on treatment, we've got to get millions of people on treatment. And we need robust and cheap drug regimens, drug distribution systems. A colleague of mine has said if we can get a cold bottle of Coca-Cola to every place in Africa, wherever you want to go, why can't we get the drugs there? We need expertise and manpower, we need healthcare financing, operational research, and simple and cheap monitoring. Everyone needs to do their part. This is I guess our part at the National Centre. I think everybody at the university should be very, very proud of this. This is the Social Health Clinic in Phnom Penh, Cambodia at its opening. We were able to secure funds to do this clinic, and we now have 1,000 people on antiretroviral treatment in Phnom Penh in Cambodia, a very, very poor country, but there are 1,000 people on treatment. And if everybody was able to do this, you can imagine the multiplying effect. To actually reduce the epidemic in Africa, treatment alone or prevention alone is not going to reduce the epidemic. We need a combined response. We have to combine prevention and treatment. There's no point in fighting one versus the other, and this is some example of some very good modelling about what would happen if we just did one or the other. So we have to move beyond the lack of a common agenda and leadership in implementation. The wide-scale introduction of these drugs in developing countries requires a really concerted global effort. It has to be a very broad coalition of the public sector, the private sector, civil society and academia. And there has to be a clear division of tasks and accountability. You can't fall over each other. We have to recognise the economic realities on the ground, and this is one of, I think, the really sad things that is not happening. Like people in rich countries, people in developing countries need to be able to make a decent living out of their activities. And even if those activities involve laudable goals like providing therapy to the millions, we have to pay healthcare workers better. And I really like this quotation, the sight of the affluent young of the West wishing to protect the poor of the world from the processes that delivered their own remarkable prosperity is unutterably depressing. So we need to plan for a future without donor money and donor dependence. That's not going to be easy. The donors are doing very well at the moment, but donor fatigue does set in. And so this scale-up will only succeed and prevail if the issue of sustainable financing of healthcare for the masses has been solved. And at the end of the day, this has to be done by you signing up, like you do here, for health insurance. and we have to have robust health insurance schemes by reliable institutions and not necessarily the state, unfortunately, is a prerequisite and a priority. So just lastly, a very few words about research. There are extraordinary benefits of clinical research that I've listed there, and the most important thing is that it really reduces the likelihood that we'll get it wrong. We've got to make sure that this rollout is doing the right things. Again, the University of New South Wales, the National Centre, is doing its part. This is downtown Bangkok. This is HIVNAT, which is a clinical trials and research consortium based at the Thai Red Cross as a partnership between us here at the University of New South Wales and the University of Amsterdam. Over a 12-year period, we've put many people on clinical trials of relevance to Thailand and the region. We've also provided the technical support of the Treat Asia network, sponsored by the American Foundation for AIDS Research, which collects data on treatments outcomes in many centres in the Asia Pacific. This research has to be funded, and we've tried to push that. As many of you will know, we had the International AIDS Society conference here successfully last July, and we got together to sign on for the Sydney Declaration, which was published widely and also published particularly in the Lancet on the cover, that we call on national governments, bilaterals, multilaterals and private donors to allocate 10% of all resources for HIV programming to research. We've got to get this right. If the donors see that we're not doing this right and the rollout fails and we don't have the right prevention programs and TB treatment programs in place, it's not going to be pretty. And the only way to do this is to have good research and evaluation. So I'd like to acknowledge many of my colleagues who've been with me for a long time on this work, colleagues at the National Centre, colleagues at HIVNAT in Bangkok, the National AIDS Program in Phnom Penh in Cambodia, the Treat Asia collaboration, and colleagues from the NIH and the World Bank. Thank you very much.